Hi, I'm David Levine. I'm co-chairman of Science Writers in New York. Behind the camera is Joe Bonner, who's recording this for YouTube. My guest tonight for the third time, and I'm very grateful, is Dr. John Moore, professor of microbiology and immunology at Weill Cornell Medicine. He's an expert on vaccine research, and he's talked to us about all kinds of stuff. And originally, we had hoped to do this with some people in India, but it just didn't work out with the time differences. So anyway, Dr. Moore, tell me about the Indian variant. Should we be concerned about it?
Well, we should be concerned about it if it spreads here in significant quantities as a proportion of the American pandemic. It's still one of those, I think we're now supposed to call it either Gamma or Delta. There's a new WHO recommendation to change the names of these variants to Greek letters, and nobody I know has yet memorized them all, but I think the Indian one is either Gamma or Delta. So if it spreads widely in the States, it could cause some problems for two reasons. One, appears to be very transmissible. There's very preliminary data out of the UK suggesting that it may even be more transmissible than B117, the UK variant now known as Alpha. So if it's outcompeting B117, then it's pretty transmissible. And therefore it would do the same in the States if it spread here in any significant amount. It's also relatively antibody resistant. Now, we still don't have a good readout on this yet because it's not been long enough to study it in the kinds of laboratory assays that are being done for the better known variants. Very early preprints, one out of India and one out of the UK, suggest that it is more resistant than B117, which isn't really resistant at all, and less resistant than the South African B1351 virus that is the most resistant of them all. So again, of all of the variants that we've studied, the B1351 is the most resistant, and the Indian B1617 seems to be in between. It's significantly resistant, but not quite as bad as the South African. So we would not want to see a virus like this spread here because it could cause a degree of vaccine failure, not substantial, but a degree. And of course, it's more transmissible. So let's hope that at present, it's pretty low. I mean, very few cases, but let's hope it stays like that. It's becoming a significant concern in the UK, where the UK British government, in all its wisdom, didn't put in a travel restriction for India for at least 2 weeks after it should have done because of some trade deal with the Indian government that was considered to be a higher priority. It was all political, and the Brits screwed the pooch on this because there were a lot of Indian travel to Britain. And so the Indian variant is starting to spread fairly widely in the UK now. It's perhaps the dominant spreading strain on a background of fairly low transmission in Britain at the moment. Well, that causes a problem because the Brits have had this quixotic vaccination policy where they've got one dose into as many people as possible. And one dose of the vaccines that are used in Britain is just not going to cut it when you're dealing with a resistant variant like B1617. So if this variant spreads widely in the UK, it will infect a lot of people who've had one dose of the vaccine. It may not kill them, the vaccine will give a degree of protection. But it's still a troubling concern, and the Brits are now rapidly starting to change gear and roll out their second doses of AstraZeneca, Pfizer and Moderna as quickly as possible, certainly among older people. So it's triggered a rethink in government policy. The Brits have been gambling for a few months, but their vaccine policy was introduced at a time of a very strict national lockdown from mid-January till the end of March. And that helps if you want to cut down transmission rates. Of course, we never did anything like that here this year and probably never will again. But if you're rolling out a vaccine and having a lockdown at the same time is certainly beneficial to cutting transmission rates. Now they're opening up again and you have a spreading variant with a degree of antibody resistance. There's a rethink going on. So let's see how this one plays out.
So for people listening in, I thank you for listening in. Please put your questions in the Q&A box. Don't put them in the chat box because that's for me and internal things. So put them in the Q&A box and we'll get to them. So the top of the news today is about the origin of the virus, and our president is saying he wants to get to the bottom of it. Dr. Fauci said he's open to it, the idea that maybe it came from a lab. What is your thinking? So why now, and what are the implications?
Well, there's been a controversy for over a year, well over a year. It's been rekindled by a few events that have triggered more media and political attention. I think the most prominent event in reigniting this controversy were reports of 3 infected laboratory workers, or 3 laboratory workers from the Wuhan Institute, who in November, December 2019 went to a hospital with severe respiratory infections, excuse me, that were never formally diagnosed, or at least if they were never, the information was never released. I'm sure they were diagnosed. So were those 3 laboratory workers infected in their place of work, and did they have SARS-CoV-2? And we don't know. Now the Chinese may know, but we don't know. And because of those cases, I think it's triggered a reevaluation of the previous consensus that a lab leak was unlikely. So most of last year, it was widely considered that though you couldn't rule out a lab leak, because there's no evidence to rule it out, it was less likely than a natural transmission. Now, I think probably equal weight is being given to both theories, and whether one or other will prevail and be a data-driven determination is an open question. And you can argue either way on the basis of the science. The known science is not equivocal. You can make arguments both ways. So maybe the intelligence community will come up with some smoking gun proof through, spycraft or whatever you want to call it, or diplomacy, or and come up with something that the scientific community can't get. Or maybe there will be an unanticipated scientific breakthrough that really points in one direction or the other. And Biden has said that he's asked for an in-depth review within 90 days of last week from all the US government's intelligence resources, and let's see what happens. But then we've got to game out, what are the consequences of, I'm not saying we shouldn't know. I think we should know for all sorts of reasons, including that I'm a scientist and I like to know things. But there aren't any really good scenarios here. If it's proven to be a lab leak to the US government's satisfaction, and the Chinese government pushes back, which they almost certainly would, they have done so far, how's that going to play out? Are we going to go into, huge trade wars, Cold Wars? I don't think we're getting to World War III about it, but we would see more political hissy fits, and it would not be a pleasant environment economically. You can imagine the world putting sanctions on and trade disputes and tariffs like you've never seen before. It's not a pleasant prospect to think of the consequences of proving it was a lab leak. But if it was a lab leak and the proof emerges, we're going to have to learn to live with that.
And I guess, the best we can hope for is to make sure that there are no more lab leaks.
Well, you'd hope so. The Atlantic had a particularly good article out that I read this morning. I think it was published yesterday. And it's, it's a really long discussion of the events of the past year and the politics. I mean, there's government level politics, how the State Department responded, how it should have responded, what the Trump administration did and didn't do for China bashing reasons, but also science politics, different schools of thought in the scientific community, where was everybody involved in investigations? Did they have no vested interest? Did they have a stake in the outcome? Was the WHO investigation completely objective? Was it transparent? Did the Chinese cooperate? I mean, all of these are very interesting reads, and they don't provide an answer to the present unknown, but they certainly open your eyes as to some of the details of what went on mostly behind the scenes last year. So I thought it was fascinating. I sort of devoured it over coffee this morning.
I will have to read it. I think I know who wrote it.
Edie, I think it's Christine Edie. But anyway, I may have got that wrong. I'm doing that from memory.
Okay, so I watch TV and I see Scott Gottlieb is on a lot, and now I see he has a new book coming out.
Who does? Sorry.
Scott Gottlieb.
Yeah. Okay. I hadn't seen the book.
Yeah, well, it's coming out, but and also we see the CEOs of Pfizer and Moderna talking as well. How seriously should we take, the announcements by the CEOs of Pfizer and Moderna, or even Scott Gottlieb?
Well, it's not really their decisions. It's not whether a new round of vaccine boosting will take place. Isn't up to the CEOs of pharmaceutical companies who, while doing great work, they do want to sell more of their vaccine. So they're not objective on this, and it's just not their call. It's the decision of, the Biden administration at top level, but in practice, CDC, FDA, NIH will all be involved in that. And I expect that they will weigh up all of the available data and make a decision that's done the best interest of the public based on the best available science. And if it's appropriate to buy more vaccines from Pfizer and Moderna, and then that's fine. Let's do it. But let's find out whether and when it's necessary. Excuse me. And there are two types of boosters being discussed or being made and designed. One of them is a recipe to address antibody-resistant variants. So if a virus like B1351, the South African strain, if that spread widely in the States and started seriously compromising vaccine efficacy, you'd want to do something about it. So mRNA and protein and other various vaccine designs based on the B1351 sequence have already been made, and they're being tested in animals and in humans. And the outcome seems to be, as expected, they would give a stronger response against these antibody-resistant variants. And there's good reason to choose B1351 over other possibilities. There was nice data out of South Africa that would indicate that was the right choice. So that's a strategy to increase our protection against the scary variants, the ones that are antibody resistant.
Okay.
But they're not spreading that widely, fortunately. I mean, the last time I looked at the CDC tracker page, probably should have boned up on it today, but there's only a few % of total American infections are these antibody-resistant strains, and some of them are not that antibody-resistant. So it might not be necessary to use a booster that is designed to increase protection against an antibody-resistant strain. If they're not circulating, you wouldn't need it. So then the other question is, the other design is a third dose of the existing Pfizer and Moderna vaccines, or in J&J's case, a second dose, which I long thought would be necessary anyway. Long thought that J&J were basically a 2-dose vaccine with a 1-dose marketing gimmick to get its sales going, but that's as maybe. So would we consider a third dose of Pfizer or Moderna for simplicity? Let's just keep it on that track. Well, different vaccines are given in different schedules for different diseases, different pathogens. But one fairly common regimen is in human studies is 0, 1 month, 6 months. That's done for, I think, when I had a Hep B shot about a decade ago, that was done like that, and I'm pretty sure I forgot my 6-month dose. But what 0, 1, 6 month is not an unheard of regimen. So, it wouldn't be outlandish. But 6 months is also not a magic mark.
So I was vaccinated with my second dose of the Pfizer vaccine in February.
Yeah.
So so that means the end of August.
Yeah.
But I don't think there'll be booster shots available.
I don't think so, because I was going to say, so 6 months isn't a magic mark. It's just an indicator of a third dose sometimes being necessary for some vaccines. So what we have to look at is there a waning in protection by the standard regimen over time? And antibody responses will always decline over time, but they don't fall off a cliff. I mean, you have in infection-mediated responses, and it seems the case in vaccines, or the SARS-CoV-2 vaccines. You get a fairly rapid initial decline, and then the curve bends and becomes a gradual fade. And what we don't know is where it would be, well, for your case, in November, 6 months after August, sorry, to get my maths wrong. So we don't know what it would be. I mean, we can make extrapolations if we had data points from you every few weeks, but these studies are being done to get a guide as to what the rate of decay is. And I've seen papers on this now, at 6 months or so, and there is a drop in titer. It's several fold, but you start off with a high level, and you drop it by 5 to 10 fold. You're still at a pretty high level. So at what point do the titers drop to levels that would concern us, even assuming we knew exactly what those titers were? Well, the more it's studied and the longer it's studied, the better we'll get an idea. But it's not just titers that matter, because we have memory responses that would kick in rapidly when we re-encounter SARS-CoV-2, and that's harder to quantify the impact of those. So there's another way of looking at efficacy, and it's these real-world vaccine cohorts. So something that happened in January, February, the Israelis were among the first to roll out the mRNA vaccine, specifically Pfizer. And they have a pretty centralized healthcare system. It's not a state healthcare system, but there's a lot of centralization of data collection. And they published very early on some real-world studies demonstrating that the efficacy of the Pfizer vaccine was absolutely comparable to the kind of 95% numbers we were seeing in phase 3 trials over here. And these cohort, and there's now cohorts in the States. I've seen large-scale hospital cohorts, like Cleveland Clinic Network has one, that is tracking vaccine efficacy in a reasonably large scale. And if we have a vaccine efficacy measurement and we start to see it decline to a significant and gradual extent, that would be an indicator that it would be time to consider boosting. So, all of this kind of information is going to be collected, weighed up, and a decision taken. I have my doubts that people who got vaccinated around the January, February, I have my doubts that they'll need another vaccine dose this year. But, that's a guesstimate. It's possible. But I do think the decisions will be taken on a data-driven basis by pretty well-informed people at CDC and NIH and FDA.
Okay, so I have some questions. I'm going to first go to people who put their questions in advance. Do we know how many targets on spike are responsible for neutralization by vaccine-induced antibodies? In other words, how well can we predict which future variants might emerge to pose more of a threat for vaccine efficiency?
Well, yeah, it's a pretty good idea. There are two major neutralization sites on the spike protein, the receptor binding domain, the RBD, sometimes known as the notorious RBD. There's the N-terminal domain, the NTD, which is proportionately minor, not irrelevant, but proportionately minor. And within the RBD, there are multiple individual epitopes, some of which are more conserved than others. And there are some epitopes that defined now by broadly active monoclonal antibodies that are very well conserved. So you will lose antibody responses to some epitopes, but there's no sign that we're seeing a pan knockout. So even with B1351, compared to wild-type viruses, the titer declines are about tenfold max. 6 to 9-fold is the range. They're not 100-fold. So you lose some epitopes, you don't lose them all. Now, is it theoretically possible to evolve a variant that is more resistant? Sure. You can't say it couldn't happen. So far, it's not. The greatest selection pressure on the virus is actually for greater transmissibility between unprotected people. So antibody resistance isn't the biggest driver. Antibody resistance will become a big driver in a very strongly vaccinated population, because then a resistant virus would have a strong selective advantage. But the mutations that drive transmissibility increases, while they overlap with some antibody epitopes, they're not the same. So, so far so good. If B1351 is the worst that we get to have to deal with, the stronger vaccines like Moderna, Pfizer, Novavax, if it ever gets licensed, and I keep on saying that because it never seems to get its act together, they should be able to deal quite well. Johnson & Johnson, that company is very frustrating. They release no information on how well their vaccine does against variants. And so whereas most of the data on Pfizer and Moderna come from multiple hospital cohorts, so you set up a hospital cohort, the PI will go and recruit healthcare workers, people in her or his lab, volunteers who will agree to be bled and contribute to an observational, fairly small scale cohort. And in January, that happened all over the country for Pfizer and Moderna. But by the time J&J was rolled out, everyone in the hospitals had already had Pfizer and Moderna. So there was very few hospital workers available to join these observational cohorts, which means that the company is the only source of information. And they're just not saying. I know journalists who've called the company, said, well, you must have this data. Why aren't you releasing it? And they just politely say, we're not going to say. And, general experience with companies is if they're not releasing data, it's because the data aren't very flattering. So call me a cynic, but I bet you J&J know their vaccine has a problem with some of the common variants, and it's just not saying so. And it's about time they actually did so.
So I have a question from someone who's in the Novavax PREVENT-19 trial.
Yeah.
I finished the double-blind crossover and took it upon myself to see if I have antibodies. I do. However, as you said, there's been no approval, and it hasn't been filed. I'm second-guessing staying in the trial. You're only collecting safety data, not much of that, and we only test a booster in select individuals. Some of my fellow participants have dropped out to receive an EUA vaccine against medical advice. Is this wise? What should those of us who are in the trial do next?
Well, here's my Novavax vaccine prevent card, because I'm in that trial.
Okay.
So I had 4 doses, 2 placebo, 2 vaccine, so I'm fully vaccinated, because they did a crossover phase. So you start off in either vaccine or placebo, and then you switch to the other, so that by the time you've had 4 doses, you by definition have had active vaccine. And one of my colleagues in my lab was in the same, and our department secretary was the same. So, because the trial site was here, and it was very easy. And for me, it was completely non-reactogenic. The only way I knew which arm I'd had injected was I had a Band-Aid on in the shower the next day, and I go, oh, must have been that one. So it was a very pleasant experience in that sense, no side effects. So when are they going to release their results. Well, every time the CEO says something, it's very soon or, immediate or imminently. And you go, well, at some point, we do know that in the UK, it was highly effective in the 90% range against the standard wild-type virus. It was on a par with Moderna and Pfizer. I confidently expect it to be successful in the States because, if it works in one country, it's going to work in another. So I got a letter because, I'm not eligible for New York's Excelsior Pass, which doesn't actually matter at the moment, but at some point it might, especially if I want a free Krispy Kreme donut or something. So I got a letter from the PI saying, I'm in the trial. And then last week, the company sent out these little cards saying, you're a member of the trial, and here's your proof that you're vaccinated, at least by this experimental vaccine. I haven't tried it, showing it to any institution that says vaccines only. At some point I will, but at least they're providing some documentation. And if the vaccine does receive an EUA, that would presumably resonate as an official document. But there is a bit of a gray area.
Well, I did get the Excelsior pass, which is for people outside New York, is a New York state pass. But all they asked me was, when were you last vaccinated? They didn't ask you, was it your second dose? Was it Johnson & Johnson? They don't ask you who it was.
Yeah, I've heard about this. I mean, a colleague on the faculty council was saying that his pass was valid only for 3 months, and why was that? Well, that was obviously a bureaucratic error, and I believe it's been extended, but I don't.
Mine expires in August. My cousin who's on it said that you're just able to renew it, but they're not really asking, are you fully vaccinated? They're just asking, when was your last vaccine?
Yeah, it's just another of these evolving situations, and I think these passes are important and widely used because people who are vaccinated should have access to services that are not available to people who are not vaccinated, who choose to be not vaccinated. I think the vaccine passport concept is an important one that says, well, okay, well, you can make your choice, your body, your choice, but you're not going on this cruise, or you're not going on this plane, or whatever, that's your choice. I think that it should be a driver towards universal vaccination.
Okay. And someone asked, please discuss giving vaccination to children without long-term safety data yet available. The cost benefits of low risk use seems quite relevant to me.
Well, again, you can't have long-term safety data without a long-term, by definition. So we don't know what a vaccine safety pattern would be in 10 years. We can't. It's not possible. So we have short-term safety data, and we have vaccine safety data for Moderna and Pfizer in small numbers of people going back over a year now, and everything looks pretty good. So parents have decisions to make. If it was my children in that age, I would definitely get them vaccinated. I wouldn't have a moment's hesitation about it. I think the benefits outweigh the theoretical risks. Sure, most kids do not have severe side effects for COVID, but some do, and you don't want to have that. So any number, and it's a numbers game in all of this, any numerical side effects are going to be outweighed by the number of kids who would be having severe side effects to the infection. And that's the strongest argument, I think, to make. Plus, in the societal context, children are still capable of becoming infected and transmitting infection to other people around them. So if we want to stamp out the pandemic, it's important that as many children as possible be vaccinated. So I can understand parents being concerned about it because, it's the little Sally and Jimmy, and it's understandable. But if it was my decision with my kids at that age, I would definitely go for it.
Several months ago, our study showed that natural infection induced a strong response. And this study now shows that the responses last. Weisskopf says, we are hopeful that a similar pattern of responses lasting over time will also emerge from the vaccine-induced responses. I think you can click on the link below the question. You can see it.
I Is that a question about how long does protected
Um,
by natural immunity last? Okay, I can read it, so I just pulled the questions up.
okay.
So, yeah, I mean, last year, there's a fair amount of information now about um, the longevity of infection-mediated immunity, at least over 6 months. So there's papers a couple of months ago that looked at the situation in the USA around November of last year. So it was capturing people who'd become infected in the first spring wave. What was their protection against reinfection? And the kind of number that came out was around 80%, so a bit less than the stronger vaccines, but a bit stronger than J&J. So that was decent, but that was after about 5 to 6 months, and it will wane over time. And the other thing to bear in mind is that the magnitude of your antibody response to infection varies with how sick you were. So people with very mild infections, asymptomatic, or had a couple of rough days and recovered at home, they don't have particularly strong antibody responses compared to people who were in the ICU and recovered. So, and these hospital studies that looked at the longevity of, or the extent of protection tended to be biased towards hospital patients and didn't really pick up on asymptomatics, because in many cases they wouldn't know they were infected. So, yes, you get a degree of protection. Yes, it's good to have it, but you should definitely get vaccinated on top of it, at least one dose. There's some arguments that the second dose of the mRNAs doesn't add a lot to people who have had infection. So the first dose is in effect your booster. So, but I would strongly encourage anyone got infected last year to go and get vaccinated.
Okay. So here's a question. My wife and I are in our 70s. We are fully vaccinated with the Pfizer vaccine last February. We'll be flying for the first time on American Airlines from Miami to Boston, nonstop on July 13th. What should be our concerns and precautions?
Behave sensibly, follow the rules. You'll still have to wear masks at the airport and on the plane, just as you would if you were on the New York subway, which I've been on recently. Everyone was masked. So you behave with common sense, but you're vaccinated. You're very substantially protected from anything bad happening, and continue to wear your mask on the plane. I mean, okay, you have something to eat or drink. You obviously can't shovel your food through your mask, but within reason, follow the rules. And the rules are well designed and appropriate, because there are going to be some people on that plane who are not vaccinated and are therefore more of a risk of transmitting infections. But fly with comfort and enjoy life when you get there.
No, I mean, I haven't flown yet, but some part of me is thinking, well, probably now is the time to fly because the rates are low and my vaccine is still strong. But then again, it's like, yeah, then.
Yeah, I mean, that's perfectly rational. I mean, immunity will decay to some extent over time, and people at the moment are in the strongest phase of their protection. So, I mean, I'm not saying that you shouldn't fly in a few months' time. That's far from it. It's not what I'm saying. But it is perfectly. I would have no qualms flying if I had a reason to fly. I've had no qualms traveling on the train or the subway. Even before I was fully vaccinated, just wearing a mask and not doing stupid stuff.
Well, I'm not so sure. I mean, the place I want to go to, I still can't go to, and there are a lot of, I mean, you can go to some places, but you have to get a PCR test before you leave, PCR test
Yeah,
there, a PCR test when you come, and it's like, oh, okay. Doesn't
yeah,
sound like a lot of fun.
yeah. International travel has its own restrictions and rules, and each country that you're flying into will have its own regulations. And I don't have a command of them all, but you haven't got a choice. You have to follow them, and if they say you're going to have a test and/or quarantine, that's the price you pay for visiting that country. It's nothing you can do about that.
Okay, so yeah, I mean, the conferences I want to go to aren't being held. I was supposed to go to Wimbledon, but they said they were going to offer me tickets next year, not this year, because they're only offering tickets to people in England. So it's like, okay, so I'll wait. How feasible are pan coronavirus vaccines that would cover all or most variants?
Well, they're being looked at. There are publications in animal models and early stage human trials are being moved towards of designs that give broader immunity. And I don't want to get too sort of technical and nerdy on this, but a certain amount of this is a rising tide rises all boats model. So that if you have a stronger response to the vaccine, you have more crossover response to the variants. So, strong is good, and it just spills over into being able to neutralize some of the variants. There are even some of these concepts that are being put forward as protection against any future coronavirus that might ever cross over into humans, which is a bit ambitious and at the moment isn't the priority. But the argument is that if one of these vaccines can be developed, then they would be available as a very rapid rollout if and when a new coronavirus ever emerges in humans that has pandemic potential. So instead of waiting the best part of a year, which was amazingly quick last year for the vaccines, you might be able to have the same vaccine amounts available in 2 to 3 months by either having a frozen supply or by rapidly producing a proven design. So that's an interesting concept, and it's quite possibly achievable. But another coronavirus might not cross over in our lifetime, and it's hard to know exactly what it would be. I mean, you can only assay against what you know. You can't assay against what you've never found. So, but it's an interesting concept, and on some level, it is feasible. And the question of whether we can deal with the current variants, well, I kind of answered that with the boosters based on B1351, which probably will do a pretty good job if we need them.
So if someone asked, if I was vaccinated in February, how can I go to my doctor and get an antibody test and will tell me how well my vaccine is working?
Not really. The kind of tests that you can get are semi-quantitative. They don't really. They give you a yes/no answer. They don't give you a
Okay.
full readout. Your GP would probably not be able to interpret the number. I wouldn't be able to interpret the number unless I knew a vast amount about the specific test. So it's not really valuable.
Okay, I think it's the same person who wants to fly. Do you recommend using face shields while on the airplane, in addition to masks?
I personally wouldn't. Not if I was vaccinated and had a mask on. I think that uh,
Okay.
I just personally wouldn't do it. I can't. If you're comfortable doing it and you can take it on in your carry-on bag and you want to wear it, I can't see a reason not to wear it other than the personal inconvenience. And if it makes you feel better, then there's no reason not to. I just personally wouldn't do it myself.
And you can wear a regular mask, doesn't have to be an N95 or anything like that?
I've worn a regular mask all the time. I've never gone for an N95.
Okay.
But again, different people have different preferences and tolerances. Um, I just felt that the standard freebie mask I was getting that I didn't have to pay for was good enough for me. But different people will probably value themselves more greatly than I do.
Um, a follow-up to the present answer. What sort of long-term effects are of interest for the COVID vaccines?
Everything. I mean, over time, the more things that you monitor, the better. But really long-term effects tend not to happen. I mean, if you're going to see something, it's going to be in the reasonably acute phase. I mean, I can't tell you that there's no long-term effects have never been seen to vaccines. I'm not that expert on all of vaccinology, but generally tends to be fairly acute, like the anaphylactic responses that we heard about in January and December, or the kind of clotting disorders with AstraZeneca in January that occurred at a low but important rate, they were within 7 to 10 days of vaccination. I have not heard of any longer term side effects being detected, but there are tracking systems and great interest in this. So if something significant happened on a statistically meaningful basis, I'm pretty confident the systems in place all around the world now would pick them up. So everything matters.
So I spoke to a neurologist at Weill Cornell and said, would you like to talk about the neurological effects of the vaccine? He said, no. He said, I don't want to scare people because I see the worst cases. He told me about a case of someone who had very strange effects, and they found out that it was actually the person had multiple sclerosis but didn't know it, and this made it come out more.
You're talking about neurological effects?
Yes, neurological effects, yeah.
There's enough insanity around that I think there's enough craziness around the States that anything induced by vaccines would not be detectable against that background.
Right.
When you read that, crazy people think that you can transmit your vaccine via some kind of death ray to unvaccinated people and affect them by being near them, you're going, oh, what planet are we on? That's about as plausible as my theory that vaccines will enable you to breathe underwater, and some of these people should go and test my theory by diving off a boat in the middle of the Atlantic. I mean, it's just crazy. There's no answer to this, but this is America today, the QAnon era.
Okay. Is there any chance of a beneficial variant developing, for example, one that does not cause symptoms but provokes broad-based immunity to the coronavirus?
Well, again, it's you can never say never. There's been no sign of it so far, and you can't say that couldn't happen. But then it segues into, well, the story of common cold coronaviruses, endemic coronaviruses. I mean, most of us have antibodies to one or more of 3 or 4 strains of circulating common cold coronaviruses, which are not the only causes of the common cold, but they're certainly one of the commoner causes. And there was a lot of speculation, and still some papers come out on whether having these common cold antibodies was protective against getting SARS-CoV-2. And the balance of evidence is strongly, no, it doesn't work like that. There's not enough of a degree of cross-reactivity of the antibodies against the endemic common cold coronavirus to slow down the pathogenic SARS-CoV-2. So, it's being looked at. But sure, the question is a perfectly reasonable one. There is no certain answer. It's in, my answer would, my surprise would be on the pretty high level if that happened. That would be a, hey, wow, that's interesting observation. But, sometimes that happens.
Well, we still only have 41% of Americans fully vaccinated, and 51% have 1 dose. And so in January and February, people were going crazy. They were up all night on the internet, trying to make appointments for vaccines. They were having multiple browsers. They were having on their cell phone and all these things. And now vaccines are plentiful. I mean, I just got an email saying, if you want to see the immersive Van Gogh exhibit free, come and they'll be giving vaccines there, and they'll give you a free ticket.
I mean, there's a spectrum in the States between people who basically say, I will never take a vaccine under any circumstances. It's Satan's spawn. It will, make my left toenail fall out. I mean, all sorts of stuff. And there are other people who will basically willing to take a vaccine every day because they think that more is better. I mean, some of the emails I get, I've had my 2 Moderna shots. Where can I go and get my J&J? And do you think I'll get Novavax soon? You go, come on. So there are people who are reckless and willing to take anything at any time because they think more is better. And the other extreme, which you won't ever take a vaccine because they've been persuaded that there's something evil and dangerous about them. And there's everyone in between, which is probably most people. So, but we persuade the truly reluctant. Well, the real hardcore, the ones, the QAnon crowd, you're not going to persuade them. it's just not going to happen. You might as well try and persuade them that Trump isn't the president and isn't going to be reinstated in August. I mean, it's not going to happen. These people have got, firm beliefs, and you can't persuade them. But the hesitant, there are still people around who say, well, I want to see longer term data, or I haven't got round to it yet, or, there are people we've got to work on. And you see states, bribing people now. I mean, $1 billion jackpot, Krispy Kreme donuts, free Budweiser. West Virginia is offering guns. Well, I wonder how that's going to work out. If you're the kind of person who'd accept a gun as a price for getting vaccinated, you're probably the kind of person who won't get vaccinated under any circumstances. I mean, but that's West Virginia for you. That's what they're willing to do as a bribe to get vaccinated. So, it's a difficult task. I mean, and it does need to be done because the virus will continue to circulate. I mean, Washington Post has had a good articles this week on how infection rates now in the States are concentrated among non-vaccinated people, which is not surprising, but it's good to see the data. And, since non-vaccinated people are concentrated in red states, we're going to see a higher and higher proportion of the American pandemic in red states over the coming months. Now, you wonder if that will shock those governors and state representatives and whatevers into changing their attitude. It might, but I think there's been enough evidence so far that nothing will persuade the irrational to suddenly become rational when they're dealing with political power.
So in New York City, where we both live, and New York State, so a few weeks ago, you had to wear a mask, you had to do everything. And now they say, well, if you're vaccinated, you don't have to wear a mask. Outside, I went to a grocery store. You don't have to you can just go up to any cashier. You don't have to go and form a line. So, and whether they're going from 50% capacity to 100% capacity at, stadiums and Madison Square Garden. Do you think it's too quick, too fast?
I think it's a gradual process. I mean, I have to wear a mask at work, medical school, hospital. So I don't wear it in the office by myself. Obviously, that'd be pointless. Got to protect myself against computer viruses, not real ones when I'm staring at the screen. But, outside, it's mandatory. But walking down the street on the way to work now, I generally just have it hanging on my chin because, it's the middle of the summer. It's a short walk. The risk of getting infected when vaccinated under those circumstances are effectively zero. You have to wear them on the subway and on the train. You have to wear them still in grocery shops. And last time I was in one a couple of days ago, everyone was. New York's been pretty disciplined about this because of, it's what's happened to New York this time last year. Other parts of the country, it's a different setting. And, there's so much politicization again about it. Mask wearing is a political statement. That's just ridiculous. It isn't. It's a public health measure. But, different people in different parts of the country are going to respond in different ways. I'll continue to do what I continue to do, which is wear one when I have to, not wear one when it would make no sense, where there's zero infection risk. When I play cricket, we don't wear masks outdoors on a playing field in the middle of, again, our team is all vaccinated. It's not necessary, but you wear one as needed. I mean, I've never found it all that inconvenient. Sure, you're wearing a mask in a rainstorm. It makes you feel like you're being waterboarded, but that's a kind of inconvenience. It's not I just never bought into this argument that there is something punitive or massively inconvenient to wearing a mask. But I don't wear one when I don't need to.
When the pandemic started, Larry David did a public service announcement for the state of California. And he says, the government's not asking much of you. They're asking you to stay home and watch TV. He said, I can do that. So I don't really think they're asking that much of you. I started going back to the gym because I think it's okay. Rates are low. I'm vaccinated.
I mean, you know, this personal freedom thing, I mean, I just find it so much BS. I mean,
Mm.
just because somebody tells you that it's an important public health measure isn't imposing on your personal freedom to be a fool. I mean, I
Yeah.
just don't buy this. I mean, I'm naturally resistant to people telling me what to do and petty regulations and whatever. But you know, how many people do you know who had the flu last winter? I mean, virtually nobody got the flu or respiratory viruses because we were wearing masks. I mean, they're beneficial in general terms. I mean, I think there'll be a certain percentage of people who will continue to wear masks in winter after this pandemic stops because they've realized that it stops them just getting, you know, bugs in general. You know, and that's quite common in Asian countries, some Asian countries. So I think it'll see a lot more mask wearing after this pandemic is over. But you know, you see shops in Texas that say, if you come in here wearing a mask, we're going to fine you $5. You go, come on. You know, where's the person's freedom to wear a mask? You want freedom to not wear it? Well, respect people's choice about wearing one. It just becomes so insanely politicized and so nonsensical that you just wonder what the hell this country's coming to.
Can you respond to the Nature study that seems to contradict your statement that mild infections don't provide lasting, robust immunity? I don't know if you know this Nature study.
Well, I don't know which study in particular, so it's hard to comment without reading it. But
Okay.
you know, what I will say is that that there is a vast amount of publications that say the magnitude of the antibody response is proportional to the antibody titer. So the worse your infection, the higher the antibody titer. Now, I'm not saying that a mild infection gives you no antibody response. Asymptomatic infections give you an antibody response. Whether that is a response that is sustained for a prolonged period of time is a bit of an unknown. I mean, at least I don't know the answer. It doesn't mean to say you won't have any antibodies, but if you got a mild infection last March, are you still protected now? You know, I still want people to get vaccinated in that situation. I mean, reinfection rates have been well documented. And as I said earlier, the figure that I've seen published from a couple of studies was 80% protection after 6 months across a spectrum of severities of infection. So I don't know of a study that looks only at mild infections and looks at reinfection rates. That would be an interesting study, and maybe I missed it. There are thousands of papers, and you can't read everyone.
Okay. So there aren't any more questions, so that I see. So I want to wish your family good congratulations. Your daughter's getting married, and,
Have to be.
want to thank you for spending time with us. And everyone out there, if you haven't been vaccinated, I'm sure most of our audience are, but who knows? Please do get vaccinated. And next week we're actually talking to two science comedians who are both really good. I've seen them perform, and we'll have a little bit talk about what they've been doing during times of COVID, and also do a little performance. And we have several events in June, including Marshall Allen from ProPublica, talking about his new book, and psychologist Lisa D'Amour, who's a contributor to CBS and also writes the opinion column in the New York Times, and she's an expert on eating disorders. So I hope you'll attend all these events in June and beyond. And I want to thank Dr. Moore for being so generous with his time with us. And it's very rare to get such an expert to answer all the questions.
Who are the comedians next week? Who did you say next week?
Yeah, comedians, June 8th. I'll send you. It's Brian Mallow and Kash Patel, who actually works for NASA.
That'll be interesting. Good.
Yeah.
Thanks. I enjoyed it. See you soon.
Take care. Bye-bye.